All right. I think I'll get started. I don't mind if people are just standing up here, but I feel a responsibility for trying to stay on time. This afternoon, for the second half, we have 4 talks, all related to devices. I'm giving 2 about ICDs and CRT, and then we also have talks on remote monitoring and lead extraction. So I think I'll begin right now with, you can't hear with this? Oh, I'm sorry. Thank you. I apologize. So I'm going to begin with this discussion of when is an ICD too early, what you need to know about waiting periods. And this is a bit related to the comments that I made earlier about us doing the right thing and sticking to clinical data about appropriate use of devices, especially when we're all challenged financially with providing what our patients need. So I'm going to plan on talking about these 5 points. Why is there confusion about waiting periods? The second is, what are the guidelines? What are the data to support the guidelines? I'll talk a little bit about risk stratification and how does that play into making decisions. And finally, how do you handle individual patients who you might feel a device is needed but outside the guidelines? Well, why is there this confusion? Well, in our country, and it flows into yours, there are multiple guidance documents to tell us about when is it appropriate to implant a device. We have the American College of Cardiology, AHA, Heart Rhythm Society, device-based guideline document. We have the Heart Failure Society of America, the European societies and the Canadian societies all have guidelines. The American College has now got performance measures which grade us on using these devices. HRS has decided to come out with a paper detailing indications for ICDs outside the guidelines. We also have a thing called appropriate use criteria, which is for insurance carriers. And then finally, we have the government issuing what's called the National Coverage Determination, which dictates what national insurance for people with Medicare and Medicaid can be reimbursed for. So the basic misunderstanding about guidelines comes from not only clinical data, but getting confused about whether these apply to secondary or primary prevention indications for defibrillators. The waiting times apply only for primary prevention ICD implantation and do not apply to people who have cardiac arrests. So if you have a cardiac arrest, it would be ridiculous to have to wait for 3 months to implant a device when you think about it. Another area of confusion is when after myocardial infarction does cardiac arrest become not related to the MI. And what is in our documents from the ACC, as well as what's recognized by the United States government for the national coverage determination, is 48 hours. So if you have an MI within 48 hours of a cardiac arrest within 48 hours of an MI, we'll give you a pass on that. On the other hand, if the arrest is on day 4 when you're ready to go home, that qualifies as a secondary cardiac arrest, and you would qualify for an ICD implant. So this is taken directly from the US guidelines, and it's just to point out that for primary prevention, ICD therapy is indicated for patients with ejection fractions of less than or equal to 35% due to prior MI who are at least 40 days post-MI and of New York Heart Association Class 2 or 3 functional status. And then we have indications for dilated cardiomyopathy also. So why is there this 40-day waiting period? I'm going to speak now about first ischemic heart disease, and then I will address non-ischemic heart disease and dilated cardiomyopathies. Well, so after MI, we really don't know what's going to happen to the ejection fraction. The stability of the substrate is unknown. The responses to therapy are unknown. And I'm going to show you some information about how, with optimized medical therapy using beta blockers and ACE inhibitors and angiotensin blockers, we can get great improvement of the EF. Also, as I'll show you, that the device benefit is not just uncertain, but in fact, for most patients, it is clearly not helpful early post-infarction. So the recommendations for the waiting period are based on randomized controlled trials that led to both the guidelines as well as our insurance coverage decisions in our country. Well, MATA-2, the trial that is the basis for 80% of the primary prevention devices that are implanted in the US at least, evaluated the effect of prophylactic ICD implantation post-MI. And the important caveat is that patients were excluded if the myocardial infarction was within a month of when you wanted to implant and measure the ejection fraction, or within 3 months of revascularization. And revascularization can be either percutaneous intervention or coronary artery bypass grafting. So we know well that with these entry criteria, with a waiting period, there was a benefit from ICDs, and it became manifest, and I'll emphasize this again, only 9 months after randomization. And the take-home message of that is that even with a waiting period of 1 to 3 months, you still don't get benefit from a defibrillator if you wait for a bit. Well, because there was question about what to do in the waiting periods, a study was done in Germany called the Dynamite trial, which Stefan Hanloser was the PI for, and it showed that early implantation of an ICD within 6 to 40 days after infarction provided absolutely no benefit. And in the sub-analysis that was published of this, you'll see that although arrhythmic death was decreased by the implantable defibrillator, it was exactly counterbalanced by a relative increase in non-arrhythmic death, and therefore overall mortality was unchanged. Well, electrophysiologists heard this news and they said, oh, this obviously has to be an anomaly. The ICD has to work in everybody. We don't take this seriously. And then within a year, Gerhard Steinbeck published a study called the IRIS study, which implanted ICDs within 5 and 31 days of infarction, and lo and behold, not only exactly the same results for overall mortality, but the study also showed that the decrease in sudden death was equally balanced by an increase in non-arrhythmic mortality. So I think it's very clear that early implantation within the waiting periods is not appropriate. So why did this happen? Well, there have been several different explanations that have been offered. One is that the sudden cardiac death rate is reduced with early reperfusion and beta blockers so much that you don't need a defibrillator. The second is that ICDs convert sudden cardiac death to non-sudden death. The third is that ICDs cause non-sudden death and the risk counterbalances benefit. There's also arguments that you've heard about that defibrillation testing actually may worsen outcome. But what I believe is that sudden death mechanisms differ early and late after MI, with an early increased risk of non-arrhythmic sudden but still cardiac death. And let me show you the data for that. Many of us have quoted the Valiant study done by Scott Solomon in Boston, and it showed that there was an important sudden death mortality early post-infarction, and the risk was greatest in people with ejection fractions of less than 30%. Well, in this sub-study from the Valiant trial, autopsies were done in a certain subset of 105 patients. And interestingly, in those autopsies, half of them didn't have any findings to explain the sudden death. And they would be truly a sudden arrhythmic death. But half of them, 51 out of the 105 patients, had cardiac non-arrhythmic causes for their mortality, including continuing infarction, recurrent MI, and 13 myocardial ruptures. So what we're looking at with sudden death post-infarction is not necessarily arrhythmic sudden death, but it is a phenotype that can be either arrhythmic or non-arrhythmic. And so the bottom line of this sub-study is that autopsy reclassified The deaths in 17% of the patients, usually from recurrent MI, are ruptured. Sudden death due to recurrent MI and rupture was highest in the first month and then interestingly declined. And with time, then arrhythmic death overtook the structural heart diseases causes of arrhythmic death. And to my mind, this may explain the negative findings of Dynamite and IRIS, that the cause of early mortality isn't addressed by the ICD. Interestingly, just in the last month, and in the interest of time, I'm not showing this slide, but a study did post-mortem in the emergency room MR scans of patients who had died suddenly. And there was a 7% incidence of ascending aortic rupture as a cause of a sudden death. So just because somebody drops does not mean it's necessarily from the rhythm. This slide I show again to emphasize that even with a waiting period of 1 month without revascularization or 3 months with revascularization, the curves only diverge in Meta 2 after 9 months. So there is no reason to rush in during the waiting periods to implant a device. This gets to the point of optimized medical therapy and how important that is. This is from the PREDICT study, which is evaluating the use of the wearable defibrillator during the waiting period. This was just published 2 months ago. And you will notice that in the first 90 days post-infarction, with optimized medical therapy, 50% of patients with low ejection fractions improved to EFs of greater than or equal to 35% at 90 days. And it really attests the importance of treating people well medically during these waiting periods. What about revascularization? This was a poster that was done at the AHA in November of last year. And I don't know if I can get the pointer to work here, but you'll see that on the very left-hand side, you'll see that the overall ejection fraction improved in patients undergoing revascularization early post-MI from a mean of 28% to 36% post-operatively. Half of the patients achieved an improvement in ejection fraction by revascularization just in this method. So let's turn our sights now to non-ischemic cardiomyopathy. And what about at the immediate time of diagnosis, what do we make out of waiting periods there? There are 3 studies in my mind that have addressed this. The CAT study, the Scud-Heft study, and DEFINITE. And let's just look at these 3 individually. So in the CAT study, which was done in the 1990s, there were only 104 patients enrolled. They had a low ejection fraction. And importantly, they could not have had their cardiomyopathy for more than 9 months. This trial, as I'll show you, was stopped early for futility. There was no benefit from early ICD implantation. In the DEFINITE study, thank you. And in the DEFINITE study, Roger's better than I am here to get this to work. It's this one, right? Yeah, it's not showing up. In any case, in the DEFINITE study, patients had no specified time of their cardiomyopathy before being enrolled, and in Scud-Heft, they had to have had at least 3 months of optimized medical therapy before being randomized. So CAT, as I told you, was stopped for futility. There was no benefit from early implantation of the defibrillator. In the DEFINITE study, which included patients with ejection fractions of less than 36% and ventricular ectopy, there was no significant improvement in survival by the ICD. Now, a sub-study was done of this trial. Huh? Yeah, it's just not there. Yeah, it just doesn't reflect on the white. In any case, Alan Kadish looked at the subsets of patients in this trial. Remember, there was no entry criterion for time of cardiomyopathy. And he said that at 3 months, as well as at 9 months, there was benefit from the defibrillator. Well, the problem with this sub-analysis is that it breaks all statistical rules. Because as you know, if the main trial is negative, you can't try to fish for subsets that are positive. So this doesn't give us any indication that early implantation of a device helps. And to me, the most important comes from Scud-Heft, which, as you know, enrolled patients with both ischemic as well as non-ischemic heart disease. This is for the subset with non-ischemic heart disease, included 49% of the patients in SCUD-HEFT. You'll see that there was no benefit from the defibrillator until after 1 year following implantation. So again, there's no rush to early implantation in this disease subset. So when you summarize all of this, the CAT trial showed no benefit at less than 3 months or less than 9 months. Definite was a yes in quotes, but statistically it wasn't relevant because the main trial was negative. And finally, in SCUD-HEFT, yeah, there was a benefit after 9 months, but it was long after 9 months. It was 1.2 years. This next slide shows how the ejection fraction can improve, and it may be that waiting 3 months is not long enough. This is from Dan McNamara showing that when stratified by the size of the left ventricle, the left ventricular end diastolic dimension at presentation, the improvement in ejection fraction can go from 27% to 45% in a large majority of, in a large number of patients. In fact, it was 60% of patients in this study. Optimized medical therapy for heart failure is a good thing. In trying to keep all this into perspective also, you might think that the sickest patients are the ones that would benefit the most from early implantation. And this is just one of a number of studies that I could cite. This is from a sub-analysis of the META-2 study, looking at the 5 risk factors, if you will, for mortality: age greater than 70 years, higher New York Heart Association class, a BUN of just greater than 26, a long QRS duration, and the presence or absence of atrial fibrillation. If you have only one of these risk 0 or one of these risk factors, you got no benefit for 0 risk factors, you got no benefit. Only if you had 1 or 2 of these risk factors did you get benefit from the device. But when you started getting sicker and had 3 or more risk factors, the benefit was diluted. And important, in the VHR group over on the right, which is very high risk, which included patients with BUNs between 50 and 70, there was no benefit whatsoever. So renal failure just by itself in these sometimes older and sick patients nullifies the benefit of ICD therapy. Well, what happens when you do put in a device outside the guidelines and if you break the rules of timing? This study came from the Beth Israel Hospital in Boston, and the arrows on the right just highlight that in terms of comparing guideline versus non-guideline based implants, appropriate ICD therapy is less, and importantly, the death rate is 50% greater. It's 30% instead of 20% by getting a device for non-guideline based indications. It's not only not helpful, it is perhaps detrimental. And look at this, the time to death is statistically different and it's shorter if you get non-guideline based early ICD implantation. So how do you handle individual patients in the context of these waiting periods? Number one is try to practice within the scope of guidelines whenever possible. But there are certain circumstances for which the waiting period can be foregone. For example, if a patient's early post-MI with heart block and needs a pacemaker, if the ejection fraction is low, according to the American College of Cardiology appropriate use criteria that I mentioned before, you can put in a defibrillator under circumstances like that because you want to avoid opening a pocket a second time at 3 months after optimized medical therapy if the person's ejection fraction is not recovered. So that's good medicine. But what you have to do is to write it down in the chart to show that you've thought about it and you understand what the guidelines are and what you're doing. So when such a rationale occurs, just document it and write it down. And I'd like to finish with this quote from the device guideline therapy document. As with all clinical practice guidelines, the recommendations in this document focus on treatment of an average patient with a specific disorder and may be modified by patient comorbidities, limitation of life expectancy because of coexistent illnesses, and other situations that only the primary treating physician may evaluate appropriately. And what this says is you've got to do the right thing for your patient. You can't practice outside of the guidelines in every patient you see, but if there are extenuating circumstances, it can be justified, but just write it down. Thank you very much. So before I go on to my second talk, any questions or comments? Maybe we could have a microphone up here.
Gracias, doctor. ¿Qué opina de hacer estudios electrofisiológicos para inducción en pacientes postinfarto con función ventricular severamente deprimida, infarto anterior, extenso, QRS ancho, fracción de expulsión muy deprimida? ¿Qué opina de hacer un estudio electrofisiológico de inducción para decidir si hacemos un implante temprano de un ICD o lo mandamos a casa con un chaleco?
It's a very good and important question, and in fact, it was addressed in part by the MUST trial, as you know, where the induction studies were done at day 6 or after post-infarct, and there was a survival benefit with ICD implantation, but the problem with that study is the ICD was not the first-line therapy. It was only after you had failed drug trials to suppress induction. Now, that being said, if somebody has got a lot of ectopy and you're, quote, worried about them, this would be the kind of situation where doing an EP study would be reasonable. Now, my feeling about that is, number one, I don't think the heart's healed by 7 days. And I have always had trouble with the concept of understanding how an inducible arrhythmia at day 7 necessarily reflects how the heart is going to be behaving at day 30. For those of us in the United States, and it's not well appreciated, but for the national coverage determination, which provides reimbursement to hospitals and physicians for patients over 65, in fact, the induction is not paid for, or the EP is not paid for until day 30. So in the United States, our hands are a little bit constrained. But again, if you've got somebody with lots of non-sustained VT, you write it down, and then you fight for them if payment's an issue.
Doctor, le quería preguntar, hay 2 o 3 escenarios que pueden plantearse en estos periodos de espera. Uno de ellos es la presencia de una taquicardia ventricular monomorfa no sospechada isquémica. Otro de ellos, usted lo mencionó, la probabilidad de un implante de un dispositivo, y ahí quiero agregar una pregunta: si con esa tan baja fracción de eyección y necesitando estimulación permanente deberíamos pensar en CDI o en CDI-TRC. Y por último, me parece que el tercer escenario es también el síncope sospechado por taquicardia ventricular, otra vez no relacionado a isquemia, que quizás son los 3 escenarios donde podemos estar pensando que ejercemos prevención secundaria y quizás pudiéramos adelantarnos un poco. ¿Qué opina usted?
I agree with you 100% on all those issues. First of all, if somebody has monomorphic ventricular tachycardia that's over 30 seconds during a waiting period, they become secondary prevention, and these rules are out. Second of all, if somebody has certainly left bundle branch block, as I'll talk about in my next talk, and a low ejection fraction, the choice of device is up to you, and that can certainly be justified. And I can't remember the third scenario that you asked me. Oh, and syncope, yeah. And certainly somebody with ischemic disease especially who's had syncope at 6 weeks, that functionally becomes secondary prevention, because if you have excluded all the other reasonable reasons for it, that becomes secondary prevention. I agree.
Thank you. Great talk. Couple questions. One I had mentioned to you earlier is that I don't necessarily think of all non-ischemics as being the same.
Right.
The group here has a lot of experience with Chagas disease, and we have a large Chagas population in our LA clinic who have a very high mortality rate relative to our other non-ischemics. So I've been very hesitant to have prolonged monitoring periods and even to stick strictly to a 30-35% EF cutoff. At least in the guidelines, previously there was like a 2B kind of wiggle room for, I think, sarcoid and some other diagnoses, which I've sort of used in the past.
Right.
What are your thoughts on potentially some of these more high-risk groups, number one? And number two, some of our cardiomyopathy folks have used the idea that significant scar on MRI, which is therefore less likely to respond to medical therapy, might push us to implant earlier.
Yeah, in terms of orphan populations, if you will, I think that 2B concept is relevant to everything from Chagas to sarcoid, ventricular non-compaction, for example. And again, I think that's justifiable with those circumstances. I think in regard to SCAR and MRI, that's very unsettled. All of us worry about that. The Canadians actually tried to do this, to do that study, and because of funding issues, had to shut it down. And in fact, it was restricted to people with ejection fractions of over 35 with SCAR. But I don't think we have enough to do that yet. All right. I think with that, I'm going to do my second talk, if I'm smart enough to figure out how to get it up here. There it is, great. At this time, I'm going to talk about cardiac resynchronization and try to offer you some ideas about picking the right patient, if you will, and to optimize outcomes with this therapy. I don't think I need to tell any one person in this room that we know that CRT for the appropriate patient improves quality of life as well as left ventricular function. And these are early data from the first trials that were done, Miracle Contact and Miracle ICD, showing an improvement in both functional class as well as quality of life. And this translates also into improvement of myocardial function and decrease in mitral insufficiency. This is from the latest iteration of the guidelines for the implantation of CRT devices. The big difference between this and the 2008 guideline is that there's much more granularity as to the appropriateness of a device with respect to the length of the QRS. And you'll see that in the green, which is a class 1 indication, yellow is a 2A, orange is 2B, and red is class 3, don't do it. You'll see that for in the green, it's not only a low ejection fraction, but if you have a left bundle sinus rhythm and a QRS duration of greater than 150, there's a very strong recommendation for it. I'll also point out that for people with New York Heart Association NYHA class 2 symptoms, if you have a QRS duration of less than 150 milliseconds and non-left bundle branch block morphology, that can be either an IVCD or right bundle branch block. It is a relative contraindication to implant such a device. So with that background, what I'm going to take a look at is with you is the importance of optimizing medical therapy, and you know where my heart is with that already from my last talk. And I'm going to talk about choosing the right patients and then stuff that you can do during the implant to improve outcomes, specifically where to place the left ventricular lead as a function of SCAR, which we've already talked about, distance from the apex, and electrical measures that can be assessed in the laboratory. This is from Greg Fonarow from the Get With the Guidelines program in the United States, just showing that with heart failure therapy that is given to patients, beginning with ACE inhibitors, adding a beta blocker, and then a defibrillator, adhering to the guidelines and optimizing medical therapy beforehand is really, really beneficial, and we should always start with that. First of all, in terms of choosing the right patient, you obviously can't choose gender for somebody who's sitting in front of you. But I'll point out that for females versus males, there's a paradox here. That for simple ICD implantation, it turns out that females do worse than males. But for CRT implantation at the bottom there, you'll see that females do better than males. And there's some reasons for that, and it may have to do with the underlying pathology, how much ischemic disease is there, the size of the left ventricle, and so forth. But for gender, at least for CRT therapy, females do better than males. Also, getting at the type of substrate, an ideal patient that you can very firmly offer CRT therapy to anticipate benefit are those with non-ischemic heart disease. And you'll see here in the Made It CRT trial that patients with ischemic heart disease and class 1 heart failure really didn't get much benefit. Class 2 got some benefit, but for the non-ischemics with class 2, they got the greatest benefit of the whole population. The issue of bundle branch block, which I'd alluded to a moment ago, is very, very important. Now, on the left side of the screen there is the Kaplan-Meier curve for improvement in outcomes for all patients, irrespective of QRS morphology. When Boston Scientific went before the Food and Drug Administration for approval of CRT therapy, the FDA actually asked for sub-analysis of QRS morphology. And lo and behold, what was shown is that people with left bundle branch block, which is on the right there, had a huge relative risk reduction of the primary endpoint of death and the hospitalization. This slide was sent out by the manufacturer as soon as the FDA gave approval for the device. But what they didn't send out was this slide. And on the left is the same one that I showed you for left bundle branch block, but look at on the right for non-left bundle branch block. This includes the rights as well as the nonspecific interventricular conduction delay. There's actually a trend for worse outcomes there. So the first take-home message here is that although you can't choose gender and you can't choose substrate, one thing you can do is to be smart about choosing people with left bundle branch block to implant or recommend CRT therapy for. What about QRS duration? And this is from a meta-analysis looking at 5 trials. You can see them listed there at the top. But the important point there is where the QRS duration curve crosses equality with a risk ratio of 1 is at a QRS duration of 140 milliseconds. Now, when Mike Gold looked at this in the reverse trial, actually people with QRS durations of 120 to 138 had worse outcomes compared to control. And this emphasizes the importance that the duration of the QRS is important. So again, if you've got a lady who's got a left bundle branch block, a non-ischemic cardiomyopathy, and oh, by the way, the QRS duration is 150 milliseconds, you can be very firm and say, I expect that you're going to get benefit from this therapy. When you look at the composite of the trials in QRS duration, you'll see that although this includes different entry criteria and severity of heart failure and substrate, by and large, if you've got QRS durations of 130 or less, there's really very little benefit. It's only when you get to the longer QRS durations that you get a greater benefit for improvement in mortality as well as a decrease in hospitalization. So QRS duration is very, very important. The question of right bundle branch block with long QRSs always comes up. Now, as we know from our clinical experience, to have a right bundle and a QRS of over 150 milliseconds is not all that common. But this was a very, very nice paper that was presented as the late-breaking clinical trial again at AHA in 2015. And you'll notice that with right bundles, with increasing QRS duration, actually mortality systematically increases as the QRS gets longer. So to implant a CRT device in somebody with a right bundle and say, well, oh, it's because the QRS is long, is thinking about things exactly wrong when you look at the data. Intuitively, it makes sense, but it doesn't stand up when it's subjected to scientific scrutiny. So right bundles with a long QRS are not advisable patients to implant a device. What about atrial fibrillation? This comes up all the time, and this is a busy slide, and I tried to put arrows on here. The bottom line, though, is that if you have sinus rhythm and you don't have an indication and you get a CRT device, you do well. All of the other subsets, if you have, and especially atrial fibrillation, and the bottom curve there is atrial fib with CRT, benefit is diluted. That's not to say that benefit is not there, but it's one thing that goes into the equation, just like when I showed you that reverse J curve for risk factors for less good outcomes from MATA-2. The presence of atrial fibrillation dilutes the benefit of CRT therapy. This is a meta-analysis looking at AF, and again, without having a control group, without CRT at all, you can't look at the relative benefit compared to doing nothing. But at least having sinus rhythm is better than having atrial fibrillation when you're looking at responses to CRT. And this, I think, is very, very important, that if you do have atrial fibrillation, you have to ensure that true left ventricular pacing is occurring. This highlights that if you have biventricular pacing as less than 98%, you get a deterioration in responses to the therapy. What's published in the literature ranges anywhere from 92% to 98%, but the point is that a lot of irregularity, and certainly if there's fusion also, that the benefit of CRT therapy is diminished. So if you are going to implant in somebody with AF, you have to block their AV node very vigorously, whether it be with a beta blocker, calcium channel blocker, if they can tolerate it, or doing an AV junction ablation. And there's a very rich literature, especially from Europe, doing that. I have to be really hard pushed to recommend it and having difficulty to control atrial fib, because God forbid you do an AV junction ablation and somebody has a device problem and loses pacing, whether it be for an infection or a lead malfunction, that person is in great trouble. So I try to avoid that, but try to use pharmacologic therapy as much as I can to block the AV node. Well, what about dysynchrony? And I know that there's a lot of movement still out there to do echoes and say my patient's got dysynchrony or not. And this is me talking now. I just can't buy that. And the reason is that to me, the physiology of lying in an echo lab on your left side in a dark room with your eyes closed doesn't mimic what happens when you get up and walk around. Your preload changes, your afterload changes, your sympathetic nervous system changes. And this is just one study that looked at a group of patients undergoing echocardiography and the measurement of dysynchrony, and you'll see that a third during exercise, dysynchrony became evident in 20%. It didn't change in 37%, and a third of patients actually lost dysynchrony just by walking around. So I don't personally make decisions about implanting or not based on dysynchrony echocardiography. This is the data for the SCAR business that we talked about with MR, and this comes from Jerome Bax's group and then Bleecker. They graded the degree of transmyocardial scar in these 5 groups here, from 0 to up to 100%. And the important thing is here on the next slide, that if you look at the location of the LV lead over scar, not only does the presence of 50% scar abolish improvement of functional class with LV pacing. But so too, if you have all I wanted to point out with this is that you have your non-responders if you put the LV lead over scar. And then this just reemphasizes the importance of risk factors that I'd already showed you. Now, in terms of risk factors, the question of renal disease always comes up, and we talk about the benefit of a defibrillator, the importance of having a pacemaker for backup. And I just show this, there's a whole literature, of course, on renal disease, but this is a group of 50 patients who had implantable loop recorders implanted. They were on dialysis. And in this group of 50 patients, there were 6 deaths. 1 was non-sudden, so there were 5 sudden deaths. They were able to obtain ILR recordings in 4 of those patients, and in all 4 of them, bradycardia was the mechanism for the sudden death, not a ventricular tachyarrhythmia. So I want you to think seriously about BIV pacing and an implantable defibrillator and what's the mechanism of death that occurs in people with severe renal failure. And that's a discussion in of its own, but I think it just goes into our equation about, is somebody sitting in front of you, what is the benefit that you're going to quote for them for a defibrillator and for CRT? And then finally, what can you do in the operating room to optimize outcomes for CRT? Well, one is to choose a non-apical position, and it really doesn't make any difference if you're lateral. Certainly there are some people who respond who are anterior, but what's very clear is that people who have apical positions do not get the maximum amount of benefit from CRT pacing. And you can determine this easily fluoroscopically when you're putting in the device. Another thing that you can do is to use what's called the so-called QLV measure. And just use the lead as you're putting it in and measure from the onset of the QRS to the bipolar electrogram at the tip. The longer the duration, that means that you're getting to the latest portion of activation of the left ventricle. If you implant the lead there, you're activating that late activation site early, and you get benefit. And this just shows how to measure the QLV. In this example, the patient with a 90 millisecond delay would be expected to get less benefit than somebody with a 165 millisecond delay. And this is highlighted in this with 3 different groupings of 105, a middle one, and greater than 130 milliseconds, that you get not only LV remodeling, but also a clinical response the longer the QLV delay is. And if this is something that's very, very easy to measure when you're in the lab. And what's nice is that when you couple QLV with LV lead position being non-apical, you get an even improved response. And that's shown on the left, not very well highlighted on this slide. But the important point is if you choose a fluoroscopic good lead position and you're at a late activation site, you'll get a very nice outcome. And then finally, not many of us do this. I certainly don't. We don't at the University of Pennsylvania. But there are 2 trials that have been done to look at speckle tracking to tell you where is the site of late activation in the ventricle. And both of these trials, the target trial, this one, and the next one that I'll show you, are that if you target a late activation site by speckle tracking, you get improved outcomes. And this is from the starter trial, which shows the same thing, that freedom from hospitalization and death is improved by echo-guided LV lead implantation. And then finally, when people have a lead, what can you do to optimize therapy if they have not responded as well as you can? There's a literature on using echo and optimizing hemodynamics, if you will, by echo. I have trouble with those studies for the same reason that I had trouble using desynchrony measures for people lying down. But one thing that is clear is that it's very easy to look at QRS duration. And there are many signals in the literature that suggest that by changing, especially VV timing, to shorten the QRS duration the most, you can greatly improve outcomes. So you can see here that if you look at people with a long QRS duration, but have gotten a narrower QRS over there on the right side, they have a greater chance for improvement. So to summarize where I started, to answer the questions for what can you do to optimize prediction for outcome in people for CRT, begin with optimizing medical therapy. Women, non-ischemics, those with left bundle branch blocks, especially that are long, no AF, dysynchrony, whether or not you believe it. If they have little scar and an MR and no comorbidities, you can be very firm in saying, I think you'll benefit from this therapy. And then when they do have a device, and when you're putting it in, choose the LV location wisely, choose a non-apical location, and if you think about doing it and are so inclined, measuring the QLV is an easy thing to do. Thank you very much. Questions? Dr. Carrillo, let's get you a microphone.
I just speak loud. How do you see the novel technologies like multi-point pacing changing the efficacy of
I'm sorry,
polarization?
I couldn't hear. I missed.
Yes. How do you see novel technologies like multi-point pacing changing the efficacy of polarization?
Right. Dr. Carrillo has asked about new technologies in CRT, such as multi-point pacing, so that if you have a quadrupolar lead, for example, and pacing from more than one of those poles, or using different things like that, whether that will improve outcomes. Yes, I didn't put that in. There's just been a trial that's been reported that has showed benefit.
Solo dos cortitas. No sé si usted ha leído, seguramente sí, en un subanálisis del Made It CRT se demostró que solo la presencia de bloqueo de rama izquierda era suficiente como para anular los otros predictores como mujer, miocardiopatía dilatada, escara previa, etc. No sé qué opina usted al respecto. Y la otra cosa es que en el postimplante de dispositivos con terapia de resincronización, en nuestro caso, aprendimos mucho cuando los dispositivos tenían monitoreo remoto en cuanto a respondedores, porque encontrábamos pacientes asintomáticos con muchas extrasístoles ventriculares, con múltiples TVNOS sostenidas cortas, con fibrilaciones auriculares paroxísticas repetitivas breves y a veces con falla intermitente en la captura del ventrículo izquierdo. Todas situaciones que, siendo asintomáticas, bajaban el porcentaje de terapia de resincronización significativamente, y al verlas mediante el monitoreo remoto nos permitió corregirlas. No sé qué opina usted.
There are two questions. The first has to do with a recent study looking at the relative lack of importance of left bundle, and I really can't comment on that. I think that would be against the sea of literature that's there favoring the importance of left bundle. And in terms of remote monitoring, we have another talk on that. Leslie Saxon has published very nice work showing that people who do remote monitoring have better outcomes, and whether it's because it's a different population and they're motivated in their own health, or because it leads to interventions, I can't say. But the remote monitoring, I think all of us believe in very strongly, especially in the safety of it coming from the TRUST trial.
Doctor, con respecto a la reprogramación de los resincronizadores, ¿qué opina usted de programarlos de tal manera que solo estimule el electrodo del ventrículo izquierdo, o de aumentar el intervalo AB para que haya un latido de fusión con el fin de obtener un QRS más angosto? ¿Qué opina al respecto?
Again, there are two questions. One is LV reprogramming to I'm sorry, I just blanked. For the short,
Programar
oh,
la
yeah,
esti-
but just LV pacing alone. I haven't figured that out myself. It sort of makes sense that it should work, but it may be that a meeting of the wave fronts is important, and whether or not LV pacing alone works, or that you have to have some intrinsic conduction at least going through the right bundle. Whether that's necessary, I just don't know. And in terms of programming the AV delay, I guess that is one place where it would be useful, and there have been trials that have looked at smart AV, for example, that didn't pan out, to try to optimize LV filling. We haven't done that typically, and as you know, smart AV did not show a big benefit.